Hello, my name is Brian Lewis, and my presentation to a congressional committee is on preventing surgical complications. Chairman of the committee and members of Congress, thank you for your time and attention to a matter that I feel is of such great importance related to healthcare today, and that is receiving appropriate care to prevent complications. Every year it is estimated that there are approximately 1 million surgical site infections and complications that utilize more than $1.6 billion in excess hospital charges. In addition, patients pay a greater price than that through poorer outcomes, greater discomfort, and lost workdays. People in the hospital expect to get better, not worse. Results from the National Scorecard on U.S. health system performance show that hospitals are taking steps to prevent complications but have leveled out at 96%, and the benchmark is 100%. The United States has not improved since 2009. Perhaps the greatest initiative introduced in the past 10 years is the Surgical Care Improvement Project, or SCIP, core measure set. These measures were a national effort introduced in 2006 by CMS, the Medicare and Medicaid Reimbursement Organization, to standardize initiatives to help prevent complications. Specifically, these speak to infection, cardiac events, and venous thrombus events, or blood clots. Despite these standardized efforts of SCIP, results show that initiatives such as chlorhexidine bathing and tight glycemic controls, or blood sugar levels below 150 milligrams per deciliter, show no improvements in patient outcomes. The evidence for the value of less than 200 milligrams per deciliter comes from a report of Zare et al., which was published in 1997, documenting a significant reduction in the risk of sternal surgical site infections if blood glucose concentration was less than 200 milligrams per deciliter. However, a publication in 2001 raised the bar substantially, suggesting that the target should be less than 150 milligrams per deciliter. This led to institutions embracing tighter glycemic control in an effort to normalize blood glucose concentrations. However, 3 recent publications call into question the benefits of tight glycemic control as a benign risk reduction strategy. Conclusion of these publications is that such control can lead to a significant risk of hypoglycemia and death in critically ill surgical patients. That is, in an effort to improve patient outcomes, we inadvertently run the risk of creating a sentinel event. The conclusion of a Cochrane collaborative publication in 2006 was that preoperative bathing or cleansing with chlorhexidine did not significantly reduce infection in clean surgical procedures. In order to understand the importance of this issue, one must realize that the standards by which we measure outcomes are seriously flawed. Complications are only recognized if a patient is readmitted within 30 days after discharge for a condition related directly to the surgery. The death of a patient is only considered a complication if it occurs in the hospital, and no surgeon is measured to have 0 complications, even if it's true. It's always changed because it's chalked up to luck, and they receive the minimal allowed rating of 1.1% complications. Conversely, surgeons with high complication rates are downgraded based on the complexity of the procedure. Healthcare policy can make a difference in how patients recover and hold hospitals responsible for preventing complications. I am here today to implore you, the members of Congress, to institute into law a bolstered version of SCIP called SCIP Plus. The protocols as they are now written are inadequate, and I ask you to consider the following amendments. Number 1, consider a patient's BMI when prescribing antibiotics. Number 2, consider the growing resistance of post-surgical infections to first-line cephalosporins. Number 3, consider the reporting of complications beyond the 30 days post-discharge to be discoverable. Additionally, allow medical facilities the ability to create and amend their own initiatives based on their specific quality assurance performance improvements. When they recognize a risk, allow them to create solutions at an institutional level, or then report these to CMS. While it is evident that institutions' compliance with existing improvement plans are improving, unfortunately, literature shows that there has been no significant improvement in either the morbidity or mortality rate related to preventable surgical complications.